as many of you know, really kind of a renowned prosthodontist who also is involved in the surgical execution of many cases. As a little bit of background, Dr. Chen graduated here in Chicago from Northwestern University in 2001, and then after that he went to the University of California at San Francisco and completed a prosthodontic program. He also has completed an implant fellowship at Loma Linda in 2005, where he also became an adjunct professor there. He's been in private practice since 2005 in Taiwan. He focuses his practice both on the surgery and prosthodontic aspects of implant dentistry, and he's a lecturer both on the local and international level on aesthetics, implant treatment, partial extraction therapy, and bone augmentation techniques. He also is involved in education as the co-director of the American Academy of Implant Dentistry in Shanghai and Beijing for their Maxi courses. He's achieved the diplomat status in not only the American Board of Oral Implantology and Dentistry, but is also a fellow of the AAID and is a member of the Academy of Osseointegration. So we want to thank Joey for putting his hard work together to kind of really give us a great presentation. And with that, I'll turn it over to Dr. Chen and look forward to your presentation.
All right. Yeah, thank you, Beth. Thank you, George, for the kind introduction. Hello, everybody. And my name is Joey Chen. And it's a great honor and pleasure for me to be here to share with you some of my experiences and thoughts on the dynamic navigation system. And today my topic will be the applying the O-on-X or applying the dynamic navigation system on the O-on-X or O-on-4 treatment protocol. And I understand that we have a lot of audiences today, more than 100 people. And there is the level of experience, there's a wide range of level of experiences. And some of us are very experienced users of the system, but some of us are new users. So in my presentation today, I would like to, the first part of my presentation, I would cover some of the basic concepts, basically how the dynamic navigation system works. And then I will move on to talking about how to use the system to do O-on-4 or O-on-X treatment. And then compare this with our conventional surgical guide systems and how these approaches are similar or different. So let me, a little bit about my background again. And I did all my dental training in the United States, and I graduated from the Northwestern University Dental School. And as some of you might know, Northwestern University no longer has a dental school. And I was actually the last graduating class from the Northwestern University Dental School in 2001. And after dental school, I was very much interested in prosthodontics. So I went to the University of California, San Francisco, to do my specialty training in prosthodontics. And then after my pros training, I was also very interested in the surgical component of implant dentistry. So I moved to Southern California and to Loma Linda University to do an implant fellowship there. So, and after that, I moved back to Taipei, Taiwan, which is where I live now still. And I have been in private practice since then for the past 15 years. And my practice focuses mainly on implant dentistry, both the surgical aspect and the prosthetic aspect. So I provide treatment from beginning to the end, both surgery and prosthetics. Okay, so let's get started. And first, many people will ask the question, why do we need to use a navigation system? And let me share with you a case I treated a number of years ago. This patient came in with a fractured maxillary left central incisor. And on the CBCT scan image here, we can clearly see a fracture line. So after my examination and diagnosis, I decided to do this case free-handed. And I'm going to do an immediate implant placement. So I took the tooth out and then I placed the implant in the position I wanted. And after the surgery, after I completed, I took a CBCT scan. And here, I actually like what I saw. The implant went in to the exact position as I had planned, and everything looks okay. And so in this particular case here, I did a freehand surgery and everything seemed to went well and the results were good. But honestly, freehand surgery really, for it to work, it really relies on the experience level and the skill level of the operator. And the truth is, not all cases turn out looking nice like this. Here is another case I did about 15 years ago. And then, as you all can see here, the implant is really not in a very good angulation. The apical area of the implant was placed very close to the root anterior to it. And then I was lucky at the time because even though the implant was very close to the root, I still had about 1 millimeter of space between the implant and the root. So I was able to restore this case, and the patient was okay and functioning for almost 15 years. But some of you probably noticed, later on this patient came back and he had developed a big recurrent caries in this premolar here. And now this tooth becomes non-restorable. I have to take this tooth out. So now I really have a big problem because as you can see here, my implant is really close to the first premolar there. And then I have very little mesial-distal space. And to place an implant, to try to squeeze an implant in between these, in this space, it will be a very challenging task. So as we can see here, sometimes freehand surgery will really, if we're not careful enough, can really get us into some kind of trouble. So in these cases, a navigation system will really help us to place that implant in the proper or desired position. So let's talk about the computer-guided navigation system. When we talk about navigation systems, they are really, we can categorize them in one of the two categories. And the first category is the static computer-guided navigation systems. And the static guides, basically, I think everybody's familiar with this. It's basically the computer-generated surgical guides. So on the planning software, we plan the positions and the angulations are for our implants. And with the click of a button, we can have this guide fabricated or printed. And then so we can, once we get the surgical guide during the surgery, we can place them in the patient's mouth and then just do our osteotomies and place our implants according to these pre-planned positions. And the second type of navigation system is the dynamic navigation system. And for the planning stage of the dynamic navigation system, it's actually very similar to the planning software of the surgical guides. We pretty much do it similarly, and we planned the angulation and the position of the implant. And then during surgery, instead of having a surgical guide, we attach a few tags onto the patient's teeth or anatomical structure, and then we attach a guide to the surgical handpiece. And then instead of using drilling through a hole, we actually operate by looking at the computer screen, and then we can see where the drill is going. So the big advantage of the dynamic navigation system is that it allows real-time visualization of our drills and the anatomical structures during surgery. We can see exactly where our drill is going during surgery. So the dynamic navigation system being a a newer technology on the market, naturally we will have this question, is that how accurate is the dynamic navigation system? I mean, is it accurate enough, or is it accurate enough, and is it comparable to the static surgical guides? And within the last few years, there are a number of studies, and they show that the dynamic navigation system, they actually have comparable accuracy to the static computer-generated surgical guides. And usually the range of accuracy is in terms of positional deviation, it's usually within 1 millimeter of the planned position. And in terms of angular deviation, it's usually within 3 degrees. And this is actually very good, very accurate, and it is comparable to what we can achieve with regular surgical guides. And these studies, they also show that both the dynamic navigation system and the conventional surgical guides, the use of these, they are both more or significantly more accurate than freehand implant placements. And also one thing to know that with the dynamic navigation system, some studies have pointed out that with proper training and more experience using the system, the accuracy actually improve significantly over time. So that's, let me spend a few minutes talking about how the dynamic navigation system works, because this is really the part I really find very fascinating, how the dynamic navigation system, how the technology works. So for it to work, we really need to have 3 things working together. Okay, we need to have 3 pieces of information or 3 elements integrating together for this dynamic navigation system to work. And the first thing is we need to know where the anatomical structure is physically in the space. And then we need the CBCT scan image. And the third thing we need is we need to know where the instrument or where our implant drill is in space. So when we are able to put these 3 things together, then we can have a proper functioning dynamic navigation system. So this is me operating on the system in the operating room. And so for the dynamic navigation system to work, this is the software installed in the computer. And when I'm operating, I'm looking at the screen here. And on top here, we see this is the light and the camera of the system. So the first thing the camera needs to see is this jaw tag here we attach to patient's teeth. Okay, so the camera first needs to see the jaw tag, and then the camera needs to see our instrument here. Okay, here we attach a drill tag to our handpiece, and this handpiece could be a contra angle, it could be a high-speed handpiece, could be a piezo surgical handpiece, or it could be a straight handpiece. So pretty much any instrument you want to use, you can attach to you can attach the jaw tag to it. And then once the camera sees these 2 tags, then they relay the information to the computer, and then it integrated with the CBCT scan data inside the computer. So this is how the computer can, the software, the system can show us in real time where the drill is moving inside the bone. And to accurately guide the drilling process, there are 3 steps which are necessary to match the anatomical structures, the CBCT images, and the position of the instruments. And here, the navigation system I use is the Navident system. And then for the Navident system, these are the 3 steps that's required for the system to work. And I know there are different systems out there in the market, but I think they are more or less work in the same concept, in the same manner. So the 3 steps are the registration, calibration, and tracking. So the first step is the registration step. Now, the registration, the purpose of this step is to map patient's physical jaw structure and the CBCT scan image in the software, okay? We want to match the patient's teeth to the CBCT scan image. And the goal is so that the navigation system can identify where the anatomical structure is in physical space. And the way to do that, first thing we need to do, we need to attach a jaw tag to the patient's teeth. And this jaw tag, if you're working on the maxillary teeth or maxilla, you attach the upper teeth. For mandible, you attach the lower teeth. And there is also another device called the head tracker. And this is, it works like a helmet the patient wears on his head. And then this is for working on maxilla. But basically, we need to attach this device with the checkerboard-like patterns onto patient's physical anatomical structure. And then one thing that I thought is interesting is that the camera actually don't see any of the patient's physical structures, like teeth or bone or anything. The only thing the camera can see is this jaw tag, or this device with a checkerboard pattern. This is the only thing the camera can recognize. So the system needs to know where the teeth are and where the bone is when the camera sees this jaw tag. And to do that, we need to do this process called the trace registration. And this is a unique procedure that Navident has, and I know the X-Guy, they also come up with a similar process recently. And basically here, for the trace registration to work, here we have an instrument here. It looks like an Explorer, and it's called a tracer tool. And at the end of the tracer tool, we attach this checkerboard pattern. It's called a tracer tag. And also here we have another little device here called a calibrator. Okay, so what we do is we place the tip of this tracer tool onto a dimple, a little indentation on the calibrator. Okay, and when we do that and we show it to the camera, now when the camera sees the calibrator and the tracer tag, the system will know where the tip of the tracer tool is relative to the jaw tag. So basically when we do this step, initially the camera can only see the tracer tag. And then when we put the tracer tool tip onto the calibrator, now every time when the camera sees the tracer tag, it will know, the system will know where the tip of the instrument is. So we can use this instrument now to detect things, to detect any structures. And the next step is, on the software, we need to select 3 to 4 high contrast objects. Usually, preferably, I prefer to select 4 because I think with more objects, the more accurate the system will be, but you need at least 3 objects. So usually with partially edentulous patient, this will be the teeth. The high contrast object will be the teeth. So I will select 4 teeth around the arch I'm working on, and then to do this step. But for an edentulous patient, as we will see later, we will actually need to put in some bone screws for this step. So now we use this tracer tool to touch and slide over the surfaces of these 4 objects, or these 4 teeth, until 100 data points are collected for each object, for each tooth. And then this tracing of the 4 teeth will create a 3D mesh. It'll create a 3D mesh of the 4 teeth in relation to the jaw tag. Okay, so once we touch the 4 teeth with the tracer tool, the computer would know where these 4 teeth are relative to the jaw tag. And then the system, once it gets the information of the 3D mesh of the teeth, it would match it with the CBCT scan image data inside the software. Okay, so now they're matching, the computer is matching the position of the teeth to the CBCT. So from now on, when the camera sees the jaw tag, the system will know exactly where the teeth are and where the bone is. Okay, so the camera, when they see the jaw tag, now the camera can know where the anatomical structures are relative to this jaw tag. So at this point, the registration process is completed. Okay, the camera has put the CBCT scan image and the anatomical data together. Okay, the system. And the second step of this 3-step process is the calibration. And this step relates the axis and the tip of the drill or the instrument to the drill tag. Okay, so what we need to do is first we need to attach this drill tag to the handpiece. Okay, and this handpiece could be a high-speed handpiece, contra-angle, piezo surgical unit, anything you choose. And the first thing we need to do is we need to calibrate the axis of the drill. So we place the chuck of the handpiece or head of the handpiece onto a little post here on the calibrator, and this tells the system where the axis of the drill will be. And then we put the drill onto the handpiece or a burr, and we put this burr, the tip of the burr, into the indentation on the calibrator, and this will tell the system where the tip of the drill is. So now when the camera sees the drill tag, it will know the axis of the drill and also the tip of the drill. So then the third step is called the tracking, and this is the action step. Okay, this is now the camera or the system has the information on the anatomical structure in the CBCT, and then it also, after the calibration, it also has information on the drill. So when the camera sees the jaw tag and the drill tag, the system can track the movement and the location of the drill relative to the anatomical structures. And these information will be presented in real time on the computer screen. So on this target view here, we can see how close we are to the target point. And this little bar here, it indicates the depth of the drilling. And initially, it's going to be green. And then when it reaches to within 1 millimeter of the target depth, it will turn yellow. And then when it actually reaches the target depth, it will turn red. And on these two views here, we can actually see there are different cross sections, so we can actually see the position of our drill inside the bone. So here is a short video on how these 3 steps work, so it can make a little more sense to everybody. So this is a partially dentulous case. The patient is missing the mandibular left second premolar. And this is the pre-op CBCT scan. We can see the height and the width of the bone. So on the planning software, I planned the angulation and the position of the implant. And this is the registration step. I'm trying to do the trace registration here. So I put the tracer tool onto the calibrator, and then I start sliding my instrument over the 4 teeth I selected. So here on the screen, we can actually see this number going up from 1 to 100. When it reaches 100, that means 100 data point has been collected. So I can move on to trace the next tooth. So basically, we select 3 to 4 teeth around the arch, and then to do the tracing. And after we completed the tracing, we need to do a step called the accuracy check. And this is basically to verify if our tracing is correct. And the next step is the calibration. So here I'm calibrating the axis and the tip of the drill. So after that's been done, we start the tracking process, which is the actual drilling, the osteotomy. And so again here, we're seeing this in action. We're seeing the drill going down, and I'm staying pretty much on target. And here we'll see how deep the drill is, and then when it reaches within 1 millimeter, it turns yellow, and then when it reaches the depth, it will turn red. So after the initial drill, I move on to the next drill, and for each drill, I suggest we calibrate each drill again. Okay, we calibrate the length of the drill. So here I am moving through my drilling sequence. So let me just fast forward this a little bit. I'm going through my drillings. And then here, if we want to, you can also calibrate the implant. So as you're placing the implant, we can see how deep our implant is going and where our implant is being placed. See if it's still on track. So this is the case, the implant placed, and this is the postoperative CBCT scan image. Okay, so so this is a basic explanation of how the surgical navigation system works. So now let's start talking about the All-on-X treatment protocol. And the treatment protocol, basically, we can do it with the dynamic navigation system, and we can also do it with the static surgical guides. And let me say that both of these systems works very well. Okay, they all have their advantages and some disadvantages, but they're both useful and valid methods. Personally, I have been using the static surgical guides for almost 15 years, so I have some experience with the system. And then with the navigation system, I've been using it for more than a year, almost a year and a half now. And both of this system works. And then in terms of the All-on-X or All-on-4 treatment protocols or the treatments, I would suggest the use of at least one of the two systems. This case, I was asked to consult on this case just yesterday, actually. And then this was a case of a doctor did the All-on-X treatment protocol. And then immediately after the treatment, the patient started having numbness on the right side, the right mandible here. And as we can see here on the CBCT image here, what happened was on this implant on the right side here, the doctor has probably hit the anterior loop of the inferior alveolar nerve. Okay, so he was doing the surgery free-handed, and he thought he placed it at an angle enough to avoid the nerve, but actually, unfortunately, he hit the nerve here. And another thing that's quite dangerous is that we see on the image on the right side here, this implant here was actually very, very close to the lingual cortical bone border of this area. And another millimeter off to the lingual, then this implant could have perforated through the lingual cortical plate. And this could be a very, very dangerous situation. So in this type of All-on-4 or All-on-X treatment protocols, I would really recommend everybody to use some type of navigation system. If not, if we try to freehand it, this is what could have potentially happen. So first of all, let me share with you a case that I did with the static surgical guide. And let's talk about the advantages and disadvantages of this, and then we will talk about dynamic navigation system. And this was a case I did a few years ago, and this is a 57-year-old female patient. And as we can see here, for her maxilla, she's missing a number of teeth, and then the remaining dentition are mostly compromised. And this is the pre-op panoramic image, and she has 8 teeth remaining on the maxilla, and out of the 8, 3 of these teeth were actually still in okay condition, but the other 5 are non-restorable and need to be extracted. So after I discussed different treatment options with the patient and different possibilities, she elected to have all her maxillary teeth extracted and to go with fixed implant-supported prosthesis. So here we are at the day of the extraction of the teeth, and I raised the full thickness flap, and we can see the right side, the ridge is very thin. At the ridge crest here, the thickness was maybe about 2 millimeters thick. So here I had to do a GBR procedure to first increase the thickness of the ridge here. So I use some tenting screws here, and then I use a resorbable membrane to try to protect this area. And here I place my bone graft. The bone graft I used here in this particular case was 50% bio-oss and 50% FDBA. And then I cover it with a resorbable membrane, and I use a number of bone tags to secure my membrane and my bone graft. And here's the left side, and we can see that this patient in the canine, the premolar area, she had no buccal bone. So again, I had to do GBR. I used a couple of tenting screws here to support my membrane and my bone graft. Here's the bone graft placed, and then I need to secure my resorbable membrane with a number of bone tags. And for the incisors, basically I place the bone graft in the extraction socket to do socket preservation. So after the surgery, I close everything up and let the patient heal for about 6 months. And 6 months later, everything seemed to heal very well. And this is my provisional prosthesis I made. And so this provisional prosthesis, a very important function of this provisional prosthesis is that we need to have use it to verify patient's aesthetics, her function, and also her phonetics. And when everything is satisfactory, then I made a duplicate of this provisional prosthesis into a radiographic guide. And this radiographic guide would have like at least 10 these gutta percha indicators. And this is for me, the patient later will need to wear this radiographic guide to do the double scan procedure. So the patients wear the radiographic guide to do a CBCT scan. And then the second scan is just to scan the radiographic guide with the CBCT. So we can input both of the DICOM files into the planning software. And on the planning software, we can basically overlap the images and do our planning. And all these white spots we see here are the pins and the screws I placed inside patient's bone. So here I was planning for implants. And in this particular case here, I plan to place 6 implants. And the implants will be placed in the central incisors, canine, and second premolar positions on both sides. And luckily for this patient, after I did the GBR, she has adequate bone thickness. So after we did the planning, and we click the button, and then we can have our surgical guide fabricated. And this was the surgical guide fabricated. And then this was my provisional prosthesis, and it was a removable denture. So after I placed the implants, my plan was to convert this removable prosthesis into a fixed provisional bridge for the patient. So here I was in the surgery. So the first thing we need to do is we need to make sure this surgical guide fits properly, very stable inside patient's mouth, okay? Because the first thing with the surgical guide is if we, especially in a edentulous patient, if we cannot fit the surgical guide properly, if there is any, like if the position of the surgical guide is off, even by just a little bit, then when we go on to do our osteotomy preparation and implant placement, then all the implants will be off. Okay, so this is a potential issue with this type of surgical guide, is that we really need to make sure we place the surgical guide properly. And then what I did here was I put the surgical guide on. I had 3 index pin here inserted to make sure it's fixed, very stable. And then I do my pilot drilling using a flapless approach. I drill right through the soft tissue. And with the surgical guide, if we want to do flapless procedure, as it was advocated in a lot of cases, there is actually some issues with the flapless approach. And some of the issues, this is just my personal experience. I'm here just to share with you some of my experiences or some of the mistakes I have made before. And some of the issues are, number one, when you have a surgical guide and you do flapless procedure, you really cannot see the bone underneath. And when you cannot see the bone, there's a possibility that you could have drilled into a wrong spot and without knowing it, meaning that you could be drilling through the surgical guide and you're thinking, okay, I'm drilling in the middle of the bone, but in reality, you might be off to the buccal or to the lingual or mesial or distal, okay? So you won't be able to see where your drill is on bone. And then sometimes it could also that we're drilling flapless, but we're actually drilling into a spot where the bone quality is very poor. For example, in sites where we did socket preservations, and then we know that even though there are certain extraction sites where we did the socket preservation, sometimes we go back after 4, 5, 6 months, the bone quality in that site is still very poor. And sometimes even the things have not healed, we can have granulation mixing with just bone particles and there is no real bone there. And if we do the procedure flapless, then we would not be able to see this type of situation. And if we go on and place an implant in a non-bone or a very poor quality bone, then the chance of this implant having problems or fail could increase. And then another issue with flapless approach is that we're drilling through the soft tissue and we're actually drilling out the soft tissue. Okay, we're actually removing our keratinized tissue, and this could have some problems in patients who don't have enough keratinized tissue to begin with. So some of these are the issues I have with the flapless surgical approach. So for me, even if I'm using a surgical guide, after I do my initial pilot drilling, I will actually remove the surgical guide and then raise a full thickness flap to see where the bone is and where my osteotomies are. I need to make sure my initial pilot drilling is on the spots, is right on the spots or on the positions I planned. Okay, so after that, after I check the initial pilot drilling, and then I will actually put the surgical guide back on, okay? And because I have the 3 indexing pins in place, so I can know my surgical guide is back to the desired or the original position. And then I can move on, start drilling, continuing my osteotomy preparation. And with the surgical guides, actually, there could be some potential issues. And I've been using the surgical guide for almost 15 years. And then actually, unfortunately, some of the issues I had very early on, these issues have not been solved over the past 10, 15 years, because those problems I had before, I still have them today. And the first thing is, like we were just saying, with the surgical guide, we really had limited visibility of the surgical area. And so the surgical guide may need to be removed from time to time to verify our osteotomies are in the correct position and the bone are in good condition. So the limited visibility of the surgical site is a problem with the surgical guides. And then another issue I really struggle with is the surgical guides are really actually difficult to use when we're trying to place implants in a limited vertical space scenario. For example, in the posterior area, in the first molar and second molar area, and sometimes in the second premolar area, because the surgical guide has a certain size and it's kind of difficult to fit it in the patient's mouth and have a long drill trying to drill in those posterior areas. And this was something we can really struggle with. And then another thing is with the surgical guide, the tactile sensation is sometimes affected because here we're trying to drill, have a long drill, trying to put the drill through a metal sleeve inside the surgical guide, and then there is always some friction between the metal drill, between the drill and the metal sleeve. And so what could happen is that we're drilling into say a type 4 bone, a very soft bone, but we're thinking, oh, because there's some resistance as our drills are going down, we could be mistaken this for a hard bone, for a type 2 bone. And then we'll move on to going through our osteotomies without realizing this and end up with a loose implant at the very end. So this is what potentially could happen. So in this particular case, I was very careful, try to avoid those problems. So I was able to go through my osteotomy preparation and place my implants with good primary stability. And here is the picture with all 6 implants placed. And then I placed on my multi-unit abutment. And then these are the healing caps I placed on the multi-unit abutment. So now I'm going to make the conversion of my removable denture to the fixed bridge. And this is the intaglio side of my provisional removable denture. And what I usually do is I inject bi-registration material on the intaglio surface of the removable denture, and I fit it back onto the patient's mouth. So here I would get 6 indentations, and this is where my my healing caps are. So I can take this to the lab and I just drill holes in these areas. And in this particular case here, even though I placed six implants, but I've decided only to use 5 of the implants to support my provisional prosthesis. And this is not because this number 8 implant site, this number 8 implant has didn't have good primary stability, but I just find just using 4 or 5 implants to support my fixed prosthesis is easier. So I attach temporary cylinders to the multi-unit abutments and put the denture back into the patient's mouth and then connect the temporary cylinder to my removable denture. I pick up the positions of the temporary cylinders. And then on top of that, I will also make impression. And then I will send these two to my lab, okay? So on the day of the surgery, I actually won't deliver my fixed provisional prosthesis. At the end of the surgery, I send the denture and the impression to the lab, and the lab works on it overnight. So I usually have the patient come back the next day to deliver the fixed provisional bridge. And this is the panoramic image after the surgery. And then this is the temporary prosthesis. And one thing to note is that I will cut off any cantilever areas. Okay, I will avoid any cantilevers on my provisional prosthesis. So this was the prosthesis delivered the next day. So usually I have the temporary prosthesis delivered within 24 hours of the surgery. And this was the, after 4 months, I was able to start the prosthetic phase. And in this particular case, I did a full arch zirconia prosthesis, screw retained for the patient. And then this was the panoramic image. So that was the surgical, how we did the all-on-X protocol with a regular surgical guide. And as we see here, even though it's a very useful instrument or a useful method, but it can have some potential issues. So now let's talk about the all-on-X protocol with the dynamic surgical navigation. And here I have a 63-year-old male patient. And when this patient first came to me, he was sitting in the waiting room, and I saw him from far away, and I was wondering, what's that in his mouth? Is he eating something there? Like he had this thing protruding out of his mouth. And then when he actually sat in my chair, and I saw this, and I was pretty impressed, because this was fixed. It was a provisional bridge, a full arch temporary prosthesis, fixed prosthesis glued onto his teeth. And I still couldn't figure out how this patient, he said he's been walking around like this for many years. And his previous dentist just somehow trying to patch this up every time he goes. And so obviously this is not a very good situation. And this is the panoramic radiograph, and we can see this patient, he had about 4 residual roots in the mandible, and he still has a number of teeth in the maxilla, but all of these teeth are very periodontally compromised, and all of them needs to be extracted. So I went ahead and extracted all these teeth and let the patient heal for about 6 months' time. And 6 months later, the soft tissue appearance looks quite nice. Everything seems to be healthy now. And these were the CBCT scan images. And we can see for the maxilla in the anterior area, the bone is really very thin, only about 3 millimeters from the crest all the way to the apical area. And then for the posterior area, we can see that the bone is lacking in both height and width. And for the mandible, we can see after the healing here, this is where I planned to have where the teeth position should be. And we can see the patient has a knife edge ridge now. And there are a couple issues here. First, there's not enough vertical space here between my occlusal surface to the top of the crest. So basically, during surgery, the first step that we need to do is to do some ridge reduction. And then I will need to reduce this ridge first to create 1, enough vertical space, and 2, to reach a thicker area here in the bottom here so I can place my implants. So after discussing different treatment options with the patient, he decided to have a complete denture for the maxilla. And then for the mandible, we would do an implant-supported fixed prosthesis on 4 implants. So here's a video of the case, and we can see how I approach this case. And basically, the procedure sequence is that first I'll do bone reduction according to my provisional prosthesis. And then I will place 4 bone screws for the trace registration process. As we saw in the previous case, because it was a partially edentulous patient, so we actually have a number of teeth we can do the tracing on. But with edentulous patients, there's no teeth to trace on, so we actually need to put in a number of bone screws so we can have somewhere to trace on. And then we take a new CBCT scan image so we can do the planning on the new data. And we place a jaw tag for the registration. And I'll show you how to place the jaw tag because now there is no teeth for us to attach the jaw tag on. And then we'll do the trace registration and then the tracking. So at this point, 6 months after extraction, now the patient is completely edentulous. And these were the CBCT scan image for the mandible. We just saw this. So we were going to make a complete denture for this patient. And I'm going to use the Navident dynamic navigation system to do the all-on-4 approach. Now, let me explain this. These are the provisional denture setup. And for me to make a final prosthesis for the mandible, I know I need about 14 millimeters of vertical space. Okay, so here on this mandibular denture here, I measure from the occlusal surface to the denture flange, I measure 14 millimeters and I cut off the extra. Okay, so in the next step here, during surgery, here we see I place the dentures in the patient's mouth and have the patient bite down firmly. And now the flange of my denture is 14 millimeters away from my occlusal surface. So what I'm doing here is I'm taking a pilot drill and just drill at the inferior border of the denture. And I'm drilling through the soft tissue and into the bone. And basically I want to make, I made 4 holes, 4 index holes along the arch of the mandible. And these will be used as references for my bone reduction. So instead of making a bone reduction guide, I find this to be a simple method to do the bone reduction. So here you see I'm drilling the 4 holes. And after I drill the 4 holes, then I remove the denture and I make a crestal incision and then expose the ridge. And here we see these are my bone reduction holes. And so now basically what I need to do is I just need to, I need to connect. Okay, so now I need to do is I need to connect the 4 index holes. And the instrument here I use is a piezo surgical instrument. You can use a straight, like a fissure burr with straight handpiece. That will work too. And here on the left side here, initially I was thinking my hole was a little bit too deep, so I actually didn't cut so far apically. But then later on I realized I still can reduce more. So I remove this whole piece of bone out. And then here I would take a big football shaped carbide burr and just do further reduction. And you can see here I'm about a couple of millimeters shy of my indexing hole. So I will reduce the bone a little bit more in that area. And try to round off any sharp corners. So here it is, the reduction is done. And now this is a very important step because now we need to place the 4 bone screws around the arch. So 2 screws in the posterior, roughly around the second premolar area, and 2 screws around the canine area. And then I send the patient to take a new CBCT. So now we see the new CBCT scan image with these 4 bone screws in. And so the next step is on the software, we'll plan the position of our 4 implants. So here I'm planning the right posterior implant, and then the right anterior implant. And this is the left posterior implant. So these implants will be planned to tilt at about a 30-degree angle to avoid the inferior alveolar nerve. Okay, here you can see there, my plan initial was a little bit too close to that anterior loop, so I tilted the implant a little bit more to avoid the loop. And then here I'm just checking to see what's the angulation of my posterior implant relative to the occlusal surface, and it was about 30 degrees. Also checking the right side. Okay, so this is the jaw tag. Okay, now because this is a edentulous arch, so we have no teeth to attach the jaw tag on. So this is the jaw tag with the wire, and we handmade this little device with acrylic, basically attach this to the end of the jaw tag, and I drill 2 holes. So this is just an acrylic piece, plastic piece, and I drill 2 holes, and later on I will fix this to the anterior mandible here with 2 bone screws. Okay, so in the anterior area where I'm not placing the implants, I fixate this jaw tag to the mandible. I just need to make sure it's very stable. Okay, so this is actually a pretty easy device to make. And now I'm doing the trace registration on the 4 bone screws. Okay, so the bone screws are obviously very small, but we just need to circle around the screws to get our 100 data points. It's actually faster and easier to trace the screws than teeth. So here I'm drilling my, starting with my left posterior implant, and here you can actually see it in action. I try to stay on target here, and then my drill is going down, getting closer and closer to the target depth. And here on this view, you see I'm avoiding the nerve, and here I'm reaching the depth. So now continue with my drilling sequence. And in case you're wondering, I use the densa burst here for my osteotomy. So the next drill, and again, we can see where the drill is going, is inside the bone. And the big advantage for me of the dynamic navigation system is that because we don't have that surgical guide anymore, so here you can see in the posterior area, the drilling is actually quite easy. We don't have a lot of stuff in the patient's mouth, and there's plenty of room to work with. So this is a big advantage of the dynamic navigation system. And here I'm placing the implants. And then this particular site is a 4.3 by 13 millimeter implant. And now move on to the right side. And again, I'm drilling at an angle. And here we can see the implant moving inside the bone, going deeper and deeper until we reach the target depth. And on the right side here, I'm also placing a 4.3 by 13 millimeter implant. Now torque down the implant, and the implant actually has greater than 45 Newton centimeter insertion torque. So it's very, very tight and stable. Okay, so here I'm doing the 2 anterior osteotomies. So I will fast forward a little bit. Okay, again, we can see this drill going down. Okay, again, the insertion torque in these implants are greater than 45 Newton centimeters. This is the right anterior implant. So I'm just fast forwarding this a little bit. So these are the 4 implants placed. And one thing to notice is that for the posterior implant in the distal aspect, because the implant platform is flat, so in the posterior area here of the distal implants, the implant platform is actually quite a bit deeper than the bone, the ridge crest. So in those areas, we need to, I would take a round burr, straight handpiece round burr, and just remove the bone in that area a little bit more. So later on, when we place the multi-unit abutment, the abutment can seat completely. Okay, I'm talking about this area here and that. Okay, so I attached the 4 multi-unit abutments on, and the implant looks relatively good. And these are the post-operative CBCT scan images. And then the patient, so then I do the same process as the previous case. I pick up the provisional denture, and then I make an impression, and I deliver this to my technician, and the technician makes the denture, the fixed prosthesis overnight, and the patient come back the next day for the delivery of the provisional prosthesis. So this is basically the process. And then this is 3 months after the implant surgery, and everything looks very good. The radiograph, we can see the bone is still at good level. So yeah, this was actually a case I did just recently. So this is where the patient is now, and he's ready for the final prosthesis. So to conclude, both the static navigation system, that is the surgical guide, and the dynamic navigation system, to use these to do the all-on-X or all-on-4 treatment protocols, they're both very useful. But in my opinion, the dynamic navigation system does offer some advantages, and because it's less bulky, it can be used in limited vertical space cases. And a big thing for the dynamic navigation system is that it has real-time visualization of drill movements. We can see exactly where the drill is, and the accuracy can be verified at all time because we have a direct view of the surgical site. And if needed, we can modify the plan right away and make changes. Okay, so we can see the surgical field very well. And then the drilling is just like regular drilling process. So the tactile sensation is immediate and it's very good. And then we actually saves a little bit of time because we don't need to wait for the surgical guide to be made. Yeah. So this, if we're really doing this in a hurry, I can actually save some time. Okay. So I think this concludes my presentation. I hope I'm not over time too much. Yeah. So thank you very much, and I hope my experience was helpful.
Thank you, Dr. Chen. Great cases, great information. At this point,
Thank you.
does anyone have any questions for him? Or, okay.
Yes.
See, Daryl has a question.
Yes.
Light required. Do you use the light often on the unit?
I'm sorry, George, what was it?
The question here from Daryl, is the light required?
The light? You mean like my headlight?
No. The light that's on the tracker box, the box?
Yeah. It is on the whole time.
Yeah.
Because I find it to be very bright and it's very, very nice. I love the light.
Okay.
Yeah. Is that the question?
Yeah.
Oh, okay.
Joey, one of the problems I've had with this system is that you have a beautiful case, but your planning is not prosthetically directed. In other words, there's not like prosthetic information on the planning software from which you're planning the implants. And I know as you can kind of correct a lot of that stuff because you're controlling all that. But the next level is really to have all that information in the planning so that, and it not to be done really on the spot. Have you found that to be,
Right.
a workflow problem, or is that anything? How have you kind of found that?
Right. Yeah. That's a great question, George. With this, with the dynamic navigation system, or with the Navident system, I guess in particular, it would be very nice if we can have the double scan procedure as well, because with the static guides, we can do the double scan as one of the case I show, right? We have the patient do the, we make this radiographic guide and then have the patient take the CBCT with the guide in the mouth. So on the software, we can actually see the position of the teeth, and then we can know exactly where to place the implants. And with this particular case right now, I wasn't able to do that. And so what I did was I basically, before the surgery, I have the patient take a CBCT with the denture, and I use some aluminum foils. I tape it on top of the occlusal surface. So with that first CBCT, I can actually see where my teeth should be and where my relative to my bone. So I can know when I'm actually doing the planning for the implants, I can know roughly if I go in a certain position, I can still be, things can still go well. And for this particular issue, I think it is something probably we can improve on. And I know there are some doctors, Discipline presented before, or yeah, there are some ways to actually match the image, like you scan the provisional prosthesis first and then try to match it or import it onto the CBCT scan image. But honestly, I find it to be a little bit hard. So that's not what I did usually. Yeah.
Like in Taiwan, if you have a really wide ridge and it looks like you don't really need much bone reduction, let's say, and you can put these mini screws in and then do do you think do patients in Taiwan, obviously the surgery would be less invasive, which is a big plus compared to putting, huge bone reduction or a huge bone guide on. Do you think that patients, like at least in Taiwan, would they have objections to a minor first surgery where you put these bone screws in and then you put the denture on, scan them? Now you have all the prosthetic information with the bone screws in, and now you can do a secondary surgery to put the implant in. Do you think is that something you think patients would be receptive to, or do you find that to be a stumbling block in Taiwan?
I think it's okay. I think it's okay. I mean, I think it's a communication thing, right? So if we explain to the patient that, okay, this is beneficial, these are the steps necessary, I think a lot of patients will be reasonable and understanding to accept this suggestion. Yeah. I mean, obviously some patient will be scared and resistant to this. Yeah. But I think it's a reasonable, it's a possibility.
Yeah, compared to the huge flap that you have to do for a bone guide, I would say, yeah.
Right.
Yeah.
All right. Anything else? No?
Any other questions?
No questions? All right. Well, you can always contact me at beth@clarinav.com if you have any questions, and I will refer them to the appropriate resources. In the meantime, within 24 hours, you will be receiving a email to the email you registered with your CE documents, a recording of this presentation, and registration for our last in this series upcoming webinar, which will be on pterygoid and zygomatic implants with Dr. Luigi Stefanelli next Wednesday. So thank you very much. Appreciate all your input. Great presentation and input. Thank you, guys.
Thank you. Thank you very much. Thank you. Yeah, my pleasure.